who's concerned about the consequences, okay? Who recognizes that there is a duty, right? He recognizes there's a rule for journalists, and yet our reporter here is deeply conflicted, okay? Because the reporter is also aware of consequences and outcomes. And so here, many times, for many of us and our patients' families, the good consequences, and this is always contested, and it's always something we can debate and discuss, right? I mean, this is very subjective oftentimes. Whatever we think the good is outweighs oftentimes whatever rule or principle might be on point. Okay? Sometimes this gets framed up as utilitarianism, this idea that, we do the best we can for the most people, sort of a triage sort of situation. You can imagine how this sort of best for the most is a frequent concern in a context where we are worried about scarce resources. There's only so much blood. How do we allocate that precious resource? Okay. And then the third one, the professor who has to look in the mirror and feel good about herself. Here I want to suggest that for many of us, we may not use these terms so much. This one may be a little bit less familiar than the rule follower or the consequentialist, sort of situationalist. But I would suggest this one, and it goes all the way back to Aristotle, perhaps before, and it's been explored by a whole, for thousands of years now. So I want to suggest that this is also part of it. This is part of what resonates in your consciousness maybe when you're concerned about what would your mama say or your grandmother say. That's what that is. That's what this is. This is this concern about becoming a good person, being a person that you can feel good about. I mean, this is deeply entangled in our ethical decision making. Wanting to be somebody who my kids are proud of. And the idea here is that you ask this question: who am I becoming? Okay, fine. So maybe a white lie in this situation. Okay. But I'm not a liar. It's a white lie. Right? We categorize these things, don't we? I'm not a liar. I may have sped a little bit to get over here. Fine, I guess I'm a speeder. I'm not a lawbreaker. Right? So I love this. Maybe some of you saw this. Anybody see Les Mis? The film, the musical? I won't ask if anybody read the book. It's ridiculously long. I haven't read the book. But the movie and the musical will serve our purpose here briefly. Here we have Hugh Jackman, or Jean Valjean. On the far left, we have Jean Valjean as he appears early on in the story as the convict who spent a number of years in prison. Anybody remember why he's in prison? You can just yell it out. We're on video here, but the microphone, forget it. Yell out why Jean Valjean's in prison. He stole a loaf of bread, punishable by a series of terms in prison. He tried to escape, but added to his term. Anyway, he's been there a long time. He looks pretty rough. On the right-hand side, we have the rehabilitated Jean Valjean. Much later in the story, he is now no longer a prisoner. He's now a benefactor. He's the mayor of the town, owner of a business, a factory. He's a job creator, if you will. He's somebody that we can respect and admire, right? And he looks good. And yet, he's dogged by one question, right? Who is he? Is he the thief who stole a loaf of bread? And again, we have to be clear. He stole the bread to save a starving child. Is he a thief? Is he a convict? Or is he something much more laudable, much grander here, the mayor of the town, the one who makes lives wonderful? Is he a virtuous man? And it's this question that he asks throughout, and it's the question that I think the professor's asking, and I think it's the question that we, depending on how much sleep we've had, how good the friend is that we are engaging, that we're consulting, the mentor, the wise person that hopefully we all have, in our lives to be a sounding board. This is the question, I think, that's in the mix. It's in the mix along with all these rules and prohibitions and duties that we get from religion, that we get from culture, that we get from the organization, that we get from JCAHO, that we get from our professional obligations and commitments, from human rights documents. There's a whole series of rules and laws and principles that are in the mix always. And then there's always these consequences, this outcome. We've got to consider the payoff, the practical question. And then there's this one, right? So we're all in the mix here, and it's complicated and it's messy. I've broken it down here in a way too sort of clear, kind of visual, but let's not kid ourselves. We're all over the map here depending on where we are and which situation. And I just want to say here we're going to move to the clinical context, but as a general matter, and also in the clinical context, this is in the mix. This is what I think ethics, and I think awareness, back to this other slide, do I have? Yes, this is fine. Back to this bit. Recognition and understanding. Recognition and understanding that we are all over the map here. Our patients' families, our colleagues, our coworkers, those in our teams. Okay? So this is all part, I think, of what it means to be doing ethics. Okay? So, in the clinical context, life or death. Again, this sort of reflective awareness. I'm cautious of our time here. Let me just say this. You'll recall back a few slides back. I'll just flip back here. In this context, generally speaking, I was saying reflective awareness, the field of behavioral ethics, gives us a lot to sort of think about and heighten awareness around. In the clinical context, I think the analog is, again, out of the behavioral ethics thinking field, is this recognition that we're thinking along two domains often. And it's framed up in the literature as System 1 thinking versus System 2. And System 1 thinking, in the literature, the research reflects, is about sort of this knee-jerk intuition, gut, that is more often than we probably realize really driving our decision-making, particularly around ethical issues where values are in conflict. That there's an instinctual sort of impulse we have that turns out is really quite powerful. And the System 2 thinking is what we do to rationalize or justify or explain it sort of after the fact. Okay. So, again, what does all this mean? I mean, we could say so much more, but being aware that there are two different ways of sort of responding and reacting whenever we come into these crises of values. All right. Now, so the analog here for recognition and understanding. So, I talked about the frameworks and the orientations in the general sense. In the clinical setting, here in a hospital setting, well, we've got a whole slate, back to the ancients, Hippocrates and before, and certainly in the last 40 or 50 years, a robust body of literature, enough to fill the room probably with papers and books around what ethical rules, what ethical principles, what ethical frameworks should be informing how we engage with patients and patients' families and practice the art of medicine. You know these terms. We'll talk about them in just a minute when we look at this scenario. Patient autonomy, best interest of the patient. Do no harm, beneficence, do good. How do you allocate and separate and determine what's more beneficial versus overly burdensome? How do you maintain a level of truth and trust between physician and patient? Those relational dynamics, justice and fairness around who even receives health care in our society. All of these are frameworks. They're orientations. Some of you are hardcore patient autonomy people. Others of you are swayed in other directions, and oftentimes it's sort of a swirling mix of recognizing that there's value across the board, and yet sometimes there are trade-offs. How do we move forward? Okay. And then again, same Same exact bullet point from the more general description. Always humility, particularly in the clinical encounter. Let's go there. Can we go there now? Oh yeah, and success. Right? This is the title that got you in the room, in addition to the free lunch, I know, or the CME credits. Is he really going to opine on what success looks like? How it might be measured? Okay, well, we'll see if I get there or not. So, here is the scenario. I apologize for the wall of text. You probably have it in extremely small font on your slides. That's fine. But here's the setup, and then we'll explore it together a little bit further. Names have been changed to protect the patient's identities. Once it was published in Hastings Center Report, I started calling her Mrs. Hastings. So there you go. 70 years old. She's been in the surgical ICU for 11 days. Originally admitted for abdominal pain, nausea, and vomiting. She's already undergone surgery for small bowel obstruction. Prior to that first surgery, upon initial admission, it's purported that she told members of the care team, a few nurses, that she would, quote, rather die than have a colostomy. And I assume medical knowledge in this audience, but for those maybe without, this is the procedure that results in a bag, in an external device that collects waste. Fair enough? Healthcare providers will have that correct. The procedure appears to go well, this first procedure, and it does not result in an ostomy, although she does have a series of additional procedures, surgical procedures, over the next few days. But here we go. Recent discussions have included talk of a timeline to transfer Mrs. Hastings to a skilled nursing facility. She seems to be on the mend. And then, unexpectedly, overnight, it was a Friday night, Mrs. Hastings' condition radically deteriorates due to necrotic bowel. By the morning, she needs immediate surgery with the likely outcome of this procedure resulting in an ostomy. Mrs. Hastings' husband seems disoriented, confused by these new and rapid developments, and tells you that he and his wife have a friend back home with a colostomy, and, quote, it smells, and, quote, it looks bad. He says he and his wife have been together for 51 years, and he knows that his wife would not want a bag and would probably, he says, rip it off when she wakes up from surgery. At the same time, he states emphatically he does not want his wife to die. In fact, just yesterday, he thought she'd be leaving the hospital in the next few days. You explained to Mr. Hastings that his wife will probably die within the next few hours. At least this is what the surgical team is saying, if she does not undergo surgery to remove the necrotic bowel. So this was the scenario presented to me on the Saturday morning as I'm sort of fumbling around with the kids' Fruit Loops and, my pajamas are on, cartoons are on. I'm looking forward to a Saturday. But I happened to draw the short straw and was carrying the ethics consultation pager that weekend. And it went off. And this is sort of the guts of what I heard on the phone. It's embellished a little bit by what I heard when I got there to the ICU about 15, 20 minutes later. What's going on here? Do we have any ethical dilemmas? Why was I called, you think? Why summons the ethicist? And I'd like to be interactive. They tell me not to move too far away. I get out of the shot. I'd like to do it Phil Donahue style, but I don't know. I'll stay here. If you be loud, we'll do a little bit of it. It's my standard operating procedure is to do this engagement. We'll try it. Yes, sir. Exactly. So there's this folklore on the wards, right? You know how this goes down. That people have said something. Maybe there's concern on the part of one of the team members. Here's an interesting question: who do you think paged me? What member of the team you think, or otherwise a family member? But who do you think put in the ethics consult? Good guess. Good guess. It wasn't a nurse, but that is typically who would call us. It wasn't social work. They called from time to time as well. Anyone else? It wasn't the surgeon. I'm biting my tongue to go further with that. No, it wasn't the surgeon calling. It was the resident. One of the residents there at the hospital who was deeply conflicted by what he was being told by the nurses regarding what Mrs. Hastings had said, and further conflicted by what the husband's saying. Right? The husband is saying, yeah, that sounds about right. We know somebody back home. They live several hours out into the country in a very rural community, and this individual that they knew back home had a bag that smelled bad. And they had had conversations about, because Mrs. Hastings had had a history of intestinal issues. Turns out she was a very sick woman, in fact. She had actually not left her house really in the last 2 years. I would find out later. So the resident called in the ethics consultation. So the ethicist arrives wearing a cape. I don't know. I was never quite sure what. Okay, so here I am. Now what? Because what's the surgeon doing? The surgeon's not placing calls to the ethics team. The surgeon is preparing for surgery. The surgeon has a patient who's about to die imminently, for whom he can save. Okay? So, just to expedite our conversation, that's what the surgeon's doing. Well, what about the nurses and the resident? And Mr. Hastings, what are they doing? Well, what do we have to have here legally? And there's an ethical component of this as well. But before we proceed with additional surgical procedures, assuming we don't already have this, and we didn't, what do we need? Consent. And how do we typically modify or discuss what's the word before the consent? Ideally, it's informed consent, right? I mean, that's really what we want. And so it's beyond a signature on a paper, which is what the surgeon, by the time I got there, had obtained. We had a signature from Mr. Hastings on the paper signing the order for the surgery to save his wife's, to prolong his wife's life. So what am I doing there? What is ethics at this point? I mean, the surgeon's preparing the rooms. They're getting ready to move her from ICU back to the surgical room, and everybody's moving forward. I get there. I see Mr. Hastings, and he's a mess. This is a man who, he's in his early 70s, hasn't slept well in at least 11 days. He's been staying at the hospital because they live several hours away. And, he's sort of blindsided by all this. And he's asking himself, what did I just do? Because I asked him, I understand you just signed the consent for the surgery. So you feel like that was what your wife would have done if she were able to communicate with us? And he just shook his head and said, I don't know. And he was really wrestling with this. And that caused me to wrestle with what he had just done. And we had a time's of the essence here, as it often is. And she's being prepped, and the surgeon's moving forward. And the resident's sort of caught in limbo here, very uncomfortable. And one of the nurses says to me, it's just a 20-something nurse. It's just a colostomy. She'll die without it. Wouldn't she rather live? And so there's that perspective in the mix, and there's Mr. Hastings, who's a real mess and who's really demonstrating some conflict. So what is the ethicist to do? We'll just let there be a little more moments of awkward silence. I want you to really imagine if you have been carrying the ethics pager for whatever reason. There you are, the ethicist. What is going on there? What do you do? What is a job? And what's going to be a job well done? What's success going to look like? I love this question. So the question was, what about other family? Is there somebody else besides Mr. Hastings who's clearly compromised for a whole series of sleep deprivation, emotional exhaustion? There's lots of reasons why Mr. Hastings maybe wasn't the best person to approach with the consent form if we really want to know what would Mrs. Hastings want. And in Tennessee, anyway, there's a statute that lays it out. It's husband, and then it's adult child, and then it's adult sibling, and it goes on and on. 6 or 7. It's a literal hierarchy. In Indiana, my understanding, unless it's been changed without my knowledge, there's no such hierarchy, and so it's a more contested. It can be more contested. Sometimes by default in practice, you go to the spouse, but not always. In Tennessee, they were following procedure. They're following the rules that said go to the husband. Question in the back. What about other family? I'm asking myself the same question, and I discover there is. There's an adult daughter. And they're not estranged. Those of you who do social work or do ethics, there's always an estranged relative, right? Seems to, at least when I was carrying the pager, there was always somebody crawling out of the woodwork, out of the family tree, to cause real headaches at the end. Okay? Not always, but often. And so the adult daughter is on good terms with her mom and dad. She hasn't been staying at the hospital because dad's there, and she's got kids, and she's got her own life back in rural Tennessee. But we're able to get her on the phone. And we have a conversation with the adult daughter who reconfirms that mom has said for years she wouldn't want a colostomy. She wouldn't want a bag, regardless of how clean and sterile and medical breakthroughs. And it's probably not nearly as bad as what this character down in their small town is living with. But regardless, she doesn't want one. And the daughter goes on to talk about her mom, who hasn't left the house in a number of years, can no longer go to church, can no longer feels good going to the market, grocery store, going around town. She's just been in declining health for a long time. A series of not only intestinal but chronic heart issues. Just a really complicated medical history. And so we have some additional input from the adult daughter. And then I go back, and so in the context of all this, finding this out, clock's still ticking here, trying to clarify with Mr. Hastings. When you signed this document, what did you understand? Are you serious that you think your wife will wake up and rip the bag off? I asked him this question, because this is what I had heard when I first got there from the resident. And he said, well, if, the surgeon told me it would be temporary, reversible, and most likely, and if it's reversible, she'll, hang in there for a few days with it. And I said, so your understanding is that they're going to perform this procedure. Your wife will not die in the next 24 or 48 hours. She'll live. But she'll emerge from surgery with a bag, and then it will be reversible and removable in short time, in short order, soon? He said, yeah. That's what they told me. So, anybody think there's a problem with the quality of the consent that was gained? Was it informed? I don't know. The surgeon's gone at this point. The surgeon's back in the surgery suite, ready to go. Mrs. Hastings is just about ready to go. I can't track down the resident. I don't know if the surgeon said that. I don't know if Mr. Hastings heard that because he needed to hear that in order to make the decision to save his wife's life in that moment. I don't know. But what I did know at that point was that I had Mr. Hastings, I had the adult daughter, both telling me she's clear and adamant about not wanting this procedure or not wanting that outcome. And I had clarity because I did ask, maybe it was one of the nurses, is this right? Because it doesn't seem right to me. And whether it was a nurse or another consulting physician, it was clarified to me what I heard some of you smirking about, giggling about. No, this would not, most likely not a chance of this being reversible, at least not in any short time. That this would be more likely than not a permanent fixture for the remainder of her life. So, now what? Now what do you do? Now you're the ethicist. You're still the ethicist. You've got this clarity. The procedure is about to begin with what turns out to have been confused consent, not informed. Now what? Oh, okay, thank you. Question down front was, what about an advance directive? What about something in writing? Because the lawyer in me always loves to see it in writing. You know, this folklore on the wards and stuff that she may or not said, that's like double or triple hearsay. I can't use that. I need to see in writing a signed document, an advance directive, a living will, something, particularly, preferably a living will, that specifies procedurally, I do not want a bag or a colostomy or anything of the sort. That's what I need to see. And I'm asking, and I'm looking, but time's of the essence. So how good can I look? I mean, we're transitioning from paper to electronic medical. I can't find it. And nobody seems to have it. And unfortunately, what would have been very helpful, right, to run in waving. Couldn't you see the dramatics of this? So I don't have that. But and we're about to run out of time. So here we go. Without it, I ran in waving. Stop the procedure. I had to go to the nurse's station, put on the stuff, you know, the kind of blue paperish type stuff, and I'm running back there in this uniform as the ethicist, stopping the procedure. The procedure, the only procedure that will save her life. So what do you think? Was this ethics consult a success? They stopped the surgery. I got back there. I told the surgeon with as much deference and respect that I could muster, this consent is really not valid. Mr. Hastings, in fact, he gave me the language I needed. Mr. Hastings has revoked this consent. And the surgeon said, okay. Prepare comfort measures and wheel her back into one of the rooms. And moved on to another surgery. And the look, I'll never forget the look of relief on the resident's face, who was standing right there, back there in the, if you'll forgive me, in the inner bowels of the hospital, back where the surgery was about to take place. So I don't know, guys. I mean, you know, what does it mean? How do we measure this? You know, metrics are so important. What counts as success? You know, it's complicated, I think. So here are just a few points here towards our closing. I've got one more slide that I put together. You don't have it in your packet. Put it together before I came over. But, you know, what are we doing when we do, particularly clinical ethics? Are we facilitating efficiencies? Or one bioethics scholar, Nancy King, talks about really we're just floundering about, if we're honest. Are we negotiating consensus? And sometimes we see this when we have the family meeting, right? We bring the whole team together in an effort to arrive at a consensus. You know, with our fingers crossed that the patient's family or the patient gets on board. with the consensus. Is that what we're doing? Challenging the physician or maybe the nurse, somebody on the healthcare team's understanding of what really the ultimate ends of medicine are. Not just what some friends back, surgical friends of mine who say, look, it's a nail. I've been trained to hit nails. I've got a hammer. I'm hammering. Right? Versus a maybe different definition of what counts as the ends or the goods. Challenging patients' understanding. I know we do this. Realigning expectations. Recalibrating about really what's possible. And sometimes, I think often it's that last bit. That really ethics at the bedside is about clarifying. It's about listening. It's about listening to patients or patients' families who haven't been heard. And not because we aren't caring people, but because we're busy people. Because that surgeon had a whole slate of procedures to be done. Because the nurses had a whole slate of patients they were caring for. So sometimes